Hi friends, welcome to my blog ECG Basics. Today we will discuss about the heart blocks. Before going to the heart blocks, let us discuss briefly about the conduction system of the heart. As we know that impulse travels from the SA node and it activates both the right and left atrium. Then it also travels to the AV node. At AV node, there is a slight delay in the impulse, and then to his bundle it passes, and then it goes to the right and left bundle branches, and then through the Purkinje fibers, it activates the both ventricles. The delay at the AV node is usually occurs when the heart is in the diastole, so that the maximum amount of the blood can be filled in the ventricles, and when the ventricles gets depolarized or when they contract, the maximum amount of the blood can be sent to the systemic circulation. In heart blocks, uh, the defects usually occurs at the AV node or his bundle or at the bundle branch blocks, bundle branches or in the Purkinje fibers. So when there will be a defect at the AV node or in the subsequent side, the impulse will not be able to travel from the from the atrium to the ventricles. So mm, there will be unnecessarily prolongation of the impulse at the AV node, or it will not be passed effectively to the ventricles. If we see the ECG, whenever the SA node fires, the impulse first activates both right atrium and the left atrium, and it is represented by the P wave. And then the impulse gets delayed at the AV node, and this delay is represented by the PR interval. PR interval is basically the interval from the beginning of the P wave to the start of the R wave, or the we can say QRS complex. So the main defect, as we know, that the in heart blocks, there is there occurs block at the AV node, his bundles or bundle branches or the Purkinje fibers. So whenever there will be a defect at the AV node junction, the impulse will not be able to travel to the ventricles from the left atrium, and there will be more delay at the AV node. This more delay at the AV node will be represented in the ECG by the prolonged PR interval. So the PR interval will be very much prolonged. Okay, this is one of the important finding in all the patients of the heart loss. If we get prolonged PR interval, we must think of heart blocks. Let us come to the heart blocks. Depending upon the findings on the in the ECG, the heart blocks are classified into first degree, second degree. Second degree is further divided into two types, Morbitz 1 and Morbitz 2 type, and in the third degree heart block. Or in the third degree heart block, we also call it as complete heart block. Heart blocks, different degrees of heart block can be remembered with this poem. Someone has written it beautifully. If you remember this, you will have early age. You will have easy to remember. You will find it easy to remember the heart blocks. If the R is far from the P, then it must be a first degree. If PR gets longer than a QR drop, then it must be type 1 Benky-Bax. If the PR stays normal and the QRS quits, then it must be type 2 Morbitz. And if QP and QRS beat independently, then it must be third degree. Or if for first degree, far away P, Benky-Bax, longer than drop. Second degree, drop randomly. Third degree, beat independently. I will just discuss about the various degrees of the heart block, and you will find it easy to remember. by remembering these poems. The first degree heart block is usually defined when the PR interval is more than 200 milliseconds, or we can say more than 5 small scale. As we know that this is the P wave, this is sorry, this is P wave, then this is small q, R, S, and T. From the beginning of the P wave to the start of the QRS complexes, this is called PR interval. Usually it is 3 to 5 small squares, or we can say it is up to 0.12 to 0.20 milliseconds. If the PR interval is more than 200 milliseconds, or if the PR interval is more than 5 small squares, then we call it as a first degree heart block because there occurs a delay without any interruption. Delay is there, delay is prolonged, but the impulse travels from the atria to the ventricle. When do we say marked first degree heart block? When the PR interval is more than 300 milliseconds. If we see here, the PR interval is more than 5 small squares, more than 5 small squares. But here, what we see here is for every P wave, there is a QRS complex. For every P wave, there is QRS complex. PR, every P wave, there is QR complex. Only the PR interval is prolonged. That is more than 5 small squares. Whenever we get such ECG finding, we should say it is a first degree heart block. P wave will be there, QRS will be there, every QRS will be followed by the P wave. The only defect will be the prolonged PR interval. The causes of the first degree heart blocks are the any condition leading to increased vagal tone, the persons who are athletes, inferior wall MI, mitral valve surgery, myocarditis because of Lyme disease, hyperkalemia, AV nodal blocking drugs like beta blocker, calcium channel blockers, digoxin, amiodarone, and it may be normal in most of the patients. So the important finding in the first degree is increased PR interval. The P wave followed by Q wave, P wave followed by the QRS complex will be there. There will be no absent QRS complexes or no absent P wave. Only the PR interval will be prolonged. So this will be a first degree heart block. It is basically a isolated finding in most of the patient, and patient doesn't have any hemodynamic instability. No specific treatment is required for the first degree heart block. So the first degree heart block can be remembered as far from P, means QRS complexes will be far from P. That is PR interval is prolonged far from P. These are the few ECGs where we can say that PR interval. This is a small P wave submerged with a T wave. This is PR interval is prolonged more than 300 milliseconds. As such, this patient is having bradycardia and is also showing the this P wave PR interval, prolonged PR interval. Here also we can see that PR interval is prolonged. It is more than 5 small squares. Coming to the second degree heart block, it is also called Moffitt's type 1 or Wenckebach's phenomenon. Type 1, Mobit's type 1 conduction law of Ankibax phenomena. What we see is there is progressive prolongation of PR interval. As we know that PR interval is beginning of the P wave to the start of the QRS complexity. We can see the PR interval is getting prolonged for every beat. So there is progressive prolongation of PR interval. And also when the maximum progressive prolongation of PR interval is there, then we see that P wave, as we see here, P wave is not followed by the QRS complex. That is, the QRS complex is absent. The P wave is not conducted, means impulses don't pass through the AV node and we don't get the ventricular activity, that is the QRS complex. Then after that, again a new PQRS complex forms. This is PR interval, and further there is prolongation of the PR interval, further prolongation of PR interval, then again absent uh, QRS complex. So this is called type 1. We can say Moffitt's type 1 second degree heart block. So in Moffitt's type 1 or Vacuvac's heart block or second degree heart block, we will get progressive prolongation of the PR interval culminating in a non-conducted P wave. Means if this is a PR interval, there is progressive prolongation of the PR interval. Progressive prolongation of the PR interval. And a stage comes when there is maximum prolonged PR interval. Thereafter, a P wave is formed, but there is no formation of the QRS. Here we can see no QRS complex. P wave is still present. Means P wave, and these are the basically non-conductive P waves. Means the impulses they don't travel from atria to the ventricle, and ventricles fail to contract because the QRS is the activity represented by, it is the basically ventricular activity represented in the form of QRS. So we will get a P wave but no QRS complex. Then again new cycle will start. This will be a P wave, formation of QRS complexes. There is a small PR interval, means though it will be prolonged PR interval. Then in next beat, P wave will be there, more prolongation of the PR interval, then QRS complex. Then again there will be a non-conducted P wave, means P wave will be there, but there will be no QRS complex. In this, again we have to remember few things. Just remember that there will be progressive prolongation of the PR interval with non-conducted P wave. The PR interval will be longest immediately before the drop beat. Here if we see, this is the P wave. Here this is the drop beat, means no QRS complex. The PR interval will be longest here. If we see, this is the PR interval, this is the PR interval, this is the PR interval, this is the PR interval. This PR interval will be the longest before the drop beat, and PR interval is shortest immediately after the drop beat. If we see, this is the drop beat, there no beat, the PR interval, this will be the shortest, or we will say shortest immediately after the drop beat. So the PR interval will be longest before the drop beat and it will be shortest after the drop beat. Again, some other things, features which need to be noted that this is the uh, PP interval. If you see, this is the PP interval. This is the PP interval. PP interval. The PP interval usually remains constant. But the RR interval, this is the RR interval, it gradually increases. It progressively, sorry, the RR interval progressively shortens. If we see, this is here we can, if we count the boxes, small boxes, 1, 2, 3, 4, and 20 small boxes, almost 24 small boxes. If we calculate here, 1, 2, 3, 4, these will be 22. And similarly, there will be progressive shortening of the RR interval with each beat of the cycle. I think the important feature of the second degree heart block is there is progressive prolongation of the PR interval with the non-conducted P wave. That is, the PR interval will be progressively increased with each beat, and a stage will come that P wave will not be followed by the QRS complex. Then again, a new cycle will start with the progressive prolongation of the PR interval. The greatest increase in the PR interval duration is typically between the first and second beat of the cycle. So if we see, it says that there will be increase in the PR interval duration typically between the first and second beat of the cycle. Again, if we see, we get these PQRS complexes in the ratio of 3 is to 2, 4 is to 3, or 5 is to 4. If we count P wave, this is 1 P wave, this is 2 P wave, 3, 4, 5, 6, 6 P wave. And the QRS complexes 1, 2, 3, 4, 5. 5 QRS complexes. So we get these PQRS complexes in the ratio of 3 is to 2, 4 is to 3, or 5 is to 1, means 3 P wave, 2 QRS, 4 P wave, 3 QRS, 5 P wave, and 4 QRS. This is the first degree, sorry, Mobitz type 1, second degree heart block, or we can say Wenckebach's phenomena. Means there will be progressive prolongation of the PR interval followed by a non-conducted P wave. I think if you remember this much, it will be quite useful. Mobitz type 1 is usually due to reversible conduction block at the level of AV node. As we know, if this is SA node, this is AV node, there will be reversible block at the level of AV node, and malfunctioning of the AV nodal cells leads to progressive fatigue until they fail to conduct an impulse. Means there will be gradual progression of the PR interval, and a stage will come that no impulse will be transmitted from the AV node because of fatigue. And when the fatigue is over, the new cycle of progressive prolongation of the PR interval will start. And in this way, the this we get the ECG findings. So main defect is in the AV node. We get progressive prolongation of the PR interval, and there will be a missed QRS complexes. Means P wave will not be conducted further, and we will get a missed beat of QRS complex, and again the cycle will start. The causes of the Mobitz type 1 or Wenckebach's phenomena are most common causes of drugs like beta blockers, calcium channel blockers, digoxin, increased vagal tone as seen in athletes, inferior wall MI, myocarditis, mitral valve repair, tetralogy of palate repair. And clinical significance of this Moffitt's type 1 second degree heart block is that it is usually a benign rhythm causing minimal hemodynamic disturbance with low risk of progression to third degree heart block. This Moffitt's type 1 heart block can progress to third degree heart block or complete heart block, but the risk is very low. The the patients who are asymptomatic and who exhibit this Moffitt's type 1 heart block, they do not require treatment. However, the symptomatic patient usually respond to atropine, and permanent pacemaker is rarely required. So if we remember the poem for Mobit's type 1 second degree heart block, the PR interval gets longer, 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 then there is a QRS drop. And it must be a type 1 Vanky bags. Or in Vanky bags, we get longer, 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 then drop. This is Moped's type 1. In Moped's type 2 second degree heart block, there will be no progressive prolongation of the PR interval. PR interval will remain, though it will be prolonged, but it will remain constant. There will be no progressive prolongation of the PR interval. Here, if we see, the PR interval is almost constant, and there will be intermittent non-conducted P wave. As we saw in type 1, that there will be progressive prolongation of the PR interval, then we will get a P wave, and there will be no QRS. Again, we will get P wave, QRS complexes, and progressive prolongation of the. But here we will get prolonged PR interval. There will be no progressive prolongation of the PR interval. We will get non-conducted P waves, means P wave, we will have P waves and absent QRS complexes, but there will be no relation between the prolongation of the PR interval, and we will have intermittent uh, non-conductive P waves. We will get P waves with no QRS that can come after two PQRS complexes, that may come after three PQRS complexes. It is not sure that when they will be present in the ECG. So we in Moffitt's type 2, there will be prolonged PR interval, but there will be no progressive PR interval prolongation. Means it will remain constant. If it is 6 box, here it will be 6 box, here will be it's small 6 box. And we will get intermittent non-conducted P waves. Means non-conducted P waves means there will be only P wave, there will be no QRS complex. QRS complexes will be absent. Okay. So the PR interval in the conductive beats remain constant. If these are small 6 small boxes, all will show small 6 boxes. The P waves march through a constant rate. So if we see the P waves, they march through the constant rate. PP interval that will be normal. The RR interval surrounding the drought B is exact multiple of the preceding RR interval. Double the preceding R interval for a single dropped beat and triple for two dropped beats. The RR interval, suppose this is the RR interval, it is surrounding this. I again repeat, the RR interval, this is the RR interval surrounding the missed beat. This is the missed beat. Okay, it will be almost double the preceding RR interval. If we see the RR interval here, these are almost three small boxes, sorry, three large boxes, or uh, if we count the small boxes, there are 15 or 17, 18 small boxes. And here the RR interval is more than 1, 1, 2, 3, 4, 5, 6. 6 5 is 30, and this is and 3, 33, and 36. So, and the RR interval surrounding this absent beat is almost double the preceding RR interval. This is an important observation. So, in Moffitt's type 2 second degree heart block, there will be prolonged interval, but there will be no progressive prolongation of the PR interval. Means PR interval will remain constant. However, there will be intermittent non-conducted P waves. Intermittent non-conducted P waves. These are the P waves. They are non-conducted means there is no QRS complexes after this P wave. No QRS complex. No QRS. These are non-conducted P wave. Okay, we will get intermittent non-conducted P wave. There will be no progressive prolongation of the PR interval. Means PR interval will remain constant and the RR interval which is surrounding this draft beat. This is the draft beat area. It will be almost double the preceding RR interval. I hope it is clear now. Here if we see this is QRS complexes, this is P wave, this is absent QRS complexes, this is PR interval, PR interval, again here absent. So here we see PR interval is almost constant and there we get intermittent non-conducted P waves. And if we see this RR interval surrounding the uh, draft beat is almost double, or we can say triple time also the preceding RR interval. So the main mechanism why we get Morbid's type 2 is due to the failure of the conduction at the level of his Purkinje system. Means it is below the AV node. In type 1, we get the defect in the AV node. But here we get the blockade at the level below the AV node, that is in the his Purkinje system, or we can say below the AV node. Morbid's type 1 is usually due to functional suppression of the AV conduction, for example, due to drugs, reversible ischemia. But Morbid's type 2, it is more likely due to structural damage to the conductive system. Means there is a structural damage, maybe because of infarction, fibrosis, necrosis. So in type 1, second degree heart block, there is a functional suppression of the AV conduction system due to drugs or reversible ischemia. But in Morbid's type 2, there is a structural damage to the conductive system because of infarction, fibrosis, necrosis. Patients usually have pre-existing left bundle branch block or bifascicular block in patient with second degree heart block with Morbid's type 2. About 75% of the cases, in this case, uh, the conduction block is located distal to the bundle of his, producing the broad QRS. If we see, here we get broad QRS complexes. Broad QRS complexes mean they are more than 3 small squares or more than 120 milliseconds. So more than 75% cases, the patient has a conduction defect in the distal to the bundle of his and they have broad QRS complex. And in the remaining 25% cases, the conduction block is located within the his bundle itself, producing the narrow QRS complex. If we see if this is the his bundle and these are the right bundle branch and left bundle branch, 25% cases are in the uh, his are due to the conduction defect in the his bundle and they produce narrow complexes. And if the defect is distal to this his bundle, that is in the right bundle branch or left bundle branch, 75% cases they have broad QRS complexes. So if we get broad QRS complex, we should think that the blockage is below the his bundle. In this conduction block, there may be no pattern to the conduction blockade, or alternatively, there may be a fixed relationship between the P wave and the QRS complex, like 2 is to 1, 3 is to 1 means 2 P wave, 1 QRS, 3 P wave, 1 QRS. We will get either no relationship or we will have fixed relationship between the P and QRS complexes. Coming to the causes of Moffitt's type 2 second degree heart block, anterior wall MI due to septal infarction with necrosis of the bundle branches is important cause. Then we have idiopathic fibrosis of the conducting system. It is also called Lindgren disease. We have cardiac surgery patients who undergo surgery close to the septum. For example, like mitral valve repair, inflammatory condition like rheumatic fever, myocarditis, Lyme disease. Autoimmune causes include SLE, systemic sclerosis, and infiltrative myocardial diseases like amyloidosis, hemochromatosis, sarcoidosis. They also cause Moffitt's type 2 second degree heart block. Patient with hyperkalemia, patient on drugs like beta blockers, calcium channel blocker, digoxin, amiodarone, they all can show type 2 Moffitt's secondary second degree heart block. Moffitt's 2, the clinical significance is the patient with Moffitt's 2 have a very high chances of hemodynamic instability and they may present with severe bradycardia that can progress to third degree heart block. Such patient, because of hemodynamic instability, may have sudden and unexpected syncope or sudden cardiac death. The risk of ACE systole is 35% per year. Morbid 2 mandates immediate admission for cardiac monitoring, backup for temporary pacing, and ultimately such patients require permanent pacemaker implantation. Coming to the third degree or complete heart block, such patients have severe bradycardia because of absence of AV conduction. The ECG in third degree heart block shows complete AV dissociation with independent atria and the ventricular rate. Means that such patients have severe bradycardia, the atria contract their own, ventricle contract their own. Means they are not dependent. The atrial activity will not be followed by the ventricular activity. The atria will contract their own, ventricles will they contract their own. There will be complete AV dissociation, and such patients will have severe bradycardia. Here we can see P wave, there is no QRS complexes. This P wave, there is no QRS complexes. This is QRS complexes. Then again we have P wave, there is no QRS complexes. So they are totally independent of each other. So in complete heart block, there is complete absence of AV conduction with none of the supraventricular impulses conducted to the ventricle. The perfusing rhythm is maintained by junction of the ventricular escape rhythm. Such patient may have sudden history of syncope or patient can have sudden cardiac death if this heart block is prolonged. The complete heart block is usually due to Moffitt's 1 or Moffitt's type 2. If it is because of Moffitt's type 1, then there there may be because of progressive fatigue of the AV nodal cells as seen in acute phase of inferior MI. And if it is because of Moffitt's type 2, there will be conduction defect within the his Purkinje system, and these may be secondary to the septal infection seen in acute anterior MI, or they can be as a result of progressive conducting systemic disease like trifascicular block. The patient with Moffitt's type 1, they have good prognosis as they show response to atropine. The causes of complete heart block are same as that we saw in Moffitt's type 1 and Moffitt's type 2 second degree heart block. So the important causes for third degree heart block inferior wall MI AV nodal blocking agents like calcium channel blockers, beta blockers, digoxin, and idiopathic degeneration of the conductive system, for example, Lenigre or Leves disease, causing the trifascicular block. The patient with third degree heart block or complete heart block, they have very high risk of developing syncope or cardiac, sudden cardiac death. So such patients are an ideal candidate for permanent pacemaker implantation. So again, coming to the poem for remembering the heart blocks. If you remember this, it will make you easy to remember the heart blocks. If the R is far from the P, then it means it is a first degree heart block. Means if P wave is this and this R wave is quite far from P wave, means PR interval is prolonged, then it is a first degree heart block. If PR gets longer than a QRS drop, means it is a type 1 banking backs. In banky backs means the PR interval increases, then we have certain P wave and there will be no QRS. Means QRS is a drop. The PR progressive PR prolongation with absent conducted P wave, then it is a type 1 Wenckii backs. In type 2, PR interval stays normal, means it is a constant, and the QRS drops intermittently. Then it is a type 2 Bobbitt's, means PR interval will be normal, and there will be sudden non-conducted P wave, means P wave will be there, but there will be no QRS complexes. Difference between both is there is progressive PR interval prolongation, but here in this PR interval is constant. So in third degree heart block, the patient have both P wave and both QRS wave, but they both atria and ventricle they contract their own. They are not dependent on each other. So we get P wave and QRS waves independent of each other. Means if there is P wave, there will be no following QRS, and after QRS, there will be no P wave. So they are totally independent of each other. Atria will contract its own QRS complexes, or ventricle will contract its own. So it is a third degree heart block. Once again, first degree far away P, Wenckii bags means type 1 Mobitz. It is longer than drop QRS. Second degree means QRS is dropped randomly. Here the PR interval is constant. And third degree heart block, they both atria and the ventricle, they beat their own. They have no relation to each other. I hope that how to identify heart block and in ECG is clear now. I tried my best to make it understand. If you still have any query, please read the standard textbook of Shamroth or electrocardiography and you will get your concept clear from there also. Thank you very much.